Welcome to the final lecture of the VCBH lecture series for 2020. And we will resume, of course, in January, but I want to wish everybody happy holidays and hope we're off to a good year in 2021. I think most of us are feeling like it can't get here soon enough. It's my great pleasure this afternoon to have the opportunity to introduce RichardRawson, a professor of psychiatry here at the University of Vermont and co-director of the Collaboration, Education, and Dissemination Core of the Vermont Center on Behavior and Health. As many of you know, I'm sure, Rick has a long and distinguished career in addictions research, most of it spent at UCLA, where he researched a wide range of topics in addictions, but was especially well known for his work in establishing and leading the Matrix Institute of Addictions and playing a key role in their important research on psychomotor stimulants and how to treat them effectively. And I actually had the great pleasure of collaborating with Rick when he was doing some of that work, and it was a real pleasure. So Rick has all the accomplishments that go with being a senior nationally and internationally recognized expert in addictions research. He's got hundreds of publications in very esteemed journals, and is the only fellow I know whose first publication appeared in the journal Science, which predicted good things that definitely did come. He sits on advisory boards of influential scientific organizations, etc. But I want to note that Rick is a native Vermonter. I was just teased him a little bit about that how appropriate it is that I can introduce him sitting in my home in Jeffersonville, Vermont, looking out my window at a meadow that is, I'm sure, very familiar to Rick. And he completed both his undergraduate and his graduate training here, his graduate training with Harold Lightenberg, who is a very accomplished researcher and a pioneer in the development of behavioral treatments for a wide range of different behavioral disorders. Rick, I think, is a man of many talents, but the one that seems strongest is his ability to disseminate important clinical research into communities and hopefully to have them adopt it. And I don't know of anyone who is better at that. So it's really our good fortune at the University of Vermont and in the VCBH that after Rick's long distinguished career at UCLA, that he decided to return to Vermont to retire, I think, but we have interfered a little bit with that. He came back in 2016 and has been working with us ever since, and we are all the better for it. And you will hear today some of the work he's been doing on psychomotor stimulants. So Rick, please go forward. And thanks for doing it.
Thank you very much, Steve. Good afternoon, and I am going to talk today about some new information on psychostimulants. I did a talk for the Center on Rural Addiction, Stacy Sigmund's Center on Rural Addiction that has recently been established at the University of Vermont. The core talk I did was about 2 months ago, and I focused that talk primarily on treatment for stimulant use disorder. And when Nicole and I were negotiating which talks I should do for which ones, I didn't want to do the same one. So this one I focused a bit more on some of the epidemiology of stimulant use disorder and some of the new information on the impact of stimulants on users. I will end with a quick update on what we know about treatment as well, however. So I will start with a little bit of the epidemiology. There's a lot of national attention now. If it wasn't for COVID, the methamphetamine expansion of methamphetamine in the United States would probably be a something that would be getting a lot more news and media attention. Lots of methamphetamine being imported into the United States. In many parts of the United States, the rates of methamphetamine use and overdose are going up and are of great concern to policymakers. I did a talk to the New Hampshire Governor's Advisory Council day before yesterday. They're saying that their methamphetamine has sort of come out of nowhere and is now one of the leading causes of overdose death in New Hampshire. I did one about a month ago in Maine for a group there where methamphetamine is showing up. Methamphetamine has not had much visibility in Vermont, however, although just before this talk, I did a talk for the Department of Family Medicine, and in the question answer period, one of the docs from family medicine said in her work in Burlington, she's seeing a lot more methamphetamine, and she expects that we'll be seeing as the rest of the, I mean, there's no way, Vermont doesn't have a bubble over it to protect it from this expansion of methamphetamine, but it is one of the last places that we're seeing increases. The other thing I want to mention is, even though there's all this attention about methamphetamine, I think it's taken away from our concern about the issue of cocaine. And cocaine is, as I'll show you, just as big a concern. It has to do with a different geography and a different set of the population, but certainly cocaine is causing equal amounts of problems in the United States. This is a slide from Wilson Compton that sort of lays out the 21st century story of the overdose death situation, starting in the 90s or late 90s with this increase in prescription opioid deaths that increased very dramatically up until about 2010, 2011, at which point we started to see heroin deaths. Heroin came in as doctors and other groups tried to reduce the availability of painkillers and overprescribing of painkillers. Heroin came in to backfill that market and to provide opioids for people who could no longer get their Vicodin or their Oxycontin on the street. Now they could buy heroin. And for a period of about 6 or 7 years, heroin was really the driver of the overdose death problem. However, all of it's been supplanted by fentanyl. Fentanyl starting in about 2014 and shooting up. And this is stopped. My graph stops in 2017, but the slope of that line continues up through today, through 2020. Fentanyl is of course a very potent opioid and is now coming in from the drug cartels in virtually all the drugs coming in from Mexico. That is, it comes in the heroin, it comes in the methamphetamine, and it comes in the cocaine. So people who are buying cocaine and methamphetamine are also getting fentanyl. And so much of the overdose information we're seeing now is a combination of cocaine and fentanyl, methamphetamine and fentanyl, and just fentanyl itself. And we've seen this increase in stimulants to where cocaine and methamphetamine related deaths are now second only to fentanyl by itself. So this certainly is, as I said, if we weren't in the middle of this COVID epidemic, these increased and dramatically increasing death rates would be getting a lot more attention. Here's some data from basic data on the stimulant overdose rates, 2012 through 2018. Age-adjusted rate of overdose deaths for cocaine more than tripled during that 6 years. And the rate of deaths involving psychostimulants, including methamphetamine, increased 5-fold. I should also mention, I've done some talking to doctors around the state of Vermont, particularly one group in St. Albans who brought my attention to the issue of prescription stimulants, that is medications like Adderall, that they feel there's some concern about, that they've seen that There may have been some overprescribing. There's a researcher from Harvard who's doing some work on prescription stimulants. Prescription stimulant data haven't really made much of a blip in these kind of overdose death data, but I do think it's something to keep our eyes on, because these docs out in primary care in different locations in Vermont are pretty concerned about what they see as rapidly escalating doses of prescribing of these medications. But on these overdose death rates, you can see the blue line is cocaine overdose deaths and the green line is methamphetamine. And they're roughly equivalent now. This is as of 2018. The data from 2019 that I just saw are that they're just about the same number per 100,000. So we have a parallel stimulant overdose problem in the US, both cocaine and methamphetamine, and with fentanyl in much of the drug supply. This is a similar set of data on psychostimulants. And I should mention something, that the terminology is confusing. Most of us think of psychostimulants as including cocaine as a psychostimulant. However, in much of the research, in the epidemiology research anyway, there's this differentiation between cocaine and psychostimulants. So in this case, it's referring to drugs like methamphetamine, and amphetamine does not include cocaine. And this gives you some data on overdose deaths. In this category, methamphetamine involved overdose deaths. Over half of them also included opioids. And where we're seeing the biggest increase in methamphetamine use in the US is in those areas that have had big opioid epidemics. For example, and especially West Virginia. The numbers in West Virginia are off the map in terms of the rate of increase of methamphetamine related deaths. This gives you some picture of the geography of this. Psychostimulant involved overdose mortality, 2015 to 16. You see it's predominantly in Western states. When you move to 17, 18, you start to see the states in the Midwest and West Virginia as a particularly remarkably high death rate. And if you actually look at the age-adjusted overdose death rates, you can see West Virginia's death rate from methamphetamine-related deaths is about 50% higher than any other state in the country. And that really looks like it was the result of the cartels and the suppliers recognizing West Virginia had a massive opioid problem, and they brought this new product in to provide to this established market of opioid users. And they're now using methamphetamine with fentanyl in it and with the existing other drugs in the community. So it really has, this drug situation there is particularly challenging. This shows you the co-involvement of opioids and stimulants. And as you can see, it is worse east of the Mississippi, that is the amount of opioid involved, than it is in the Western states. In the Western states, we're still seeing lots of methamphetamine alone deaths without fentanyl, but every place east of the Mississippi, fentanyl is in almost all the drugs and is involved part of the overdose death picture. So we have seen these increases in both cocaine and overdose. This is some of the data on cocaine. Rates have tripled between death rates have tripled between 2013 and 18. And the remarkable thing about the cocaine overdose death problem is that it's extremely worse in the African American community. And I think there's part of the reason it's being overlooked is that a lot of the political pressure to address the methamphetamine problem is from rural states that are seeing methamphetamine for the first time. They want to get treatment services. There are currently bills in both houses of the House and the Senate on a methamphetamine relief package that I don't know, it may be in this current funding bill, but they both have bills all about methamphetamine. And my efforts have been to talk to our representatives and to some of my colleagues from California about making sure cocaine is included Because if you look at the age-adjusted death rates by race, you can see that it's the Hispanics, you've seen an increase in cocaine-related deaths, non-Hispanic whites, some increase, but the real big increase has been in the African-American community. And we have like 2 or 3 different ways we look at that. And it's every way we slice it, the death rate is in the African-American community is being driven by cocaine overdose, not methamphetamine overdose. And so these bills that are addressing the methamphetamine problem are going to miss providing resources to these populations in predominantly northeastern urban areas. That's where the overdose death rate involving cocaine is the highest, is in both northeastern urban centers as well as Chicago and Cleveland and West urban centers. So that's where the differentiation between the methamphetamine problem and the cocaine problem is predominantly the meth problem is rural and Western, or it always has been Western. It's now moving east, but still in the urban centers of the East and Midwest, cocaine is still causing an equivalent number of deaths. It's simply a different population that's being affected. So this reflects the same thing. This is overdose deaths. The dark blue line is overdose deaths associated with cocaine. The light blue is with methamphetamine. Among non-Hispanic whites, the far left panel, it's equivalent, roughly the same number of people dying from cocaine and methamphetamine. The middle set of bars is American Indians, Alaskan Natives. There you see predominantly the death rate is being driven by methamphetamine. And in the second set of bars, you can see the death rate is being driven by cocaine. So as we scramble around to address and do our whack-a-mole approach to policy and decide that today's thing we need to whack is methamphetamine, I would argue that we should definitely have it be stimulants as opposed to methamphetamine, because in the African American community, the deaths are being driven by cocaine. And as you look at this, when you look at cocaine-related deaths, in the left-hand panel, the blue line shows the increase in cocaine-related deaths over the last 15 years. And in the left-hand panel, the lower 2 lines are showing you the rate of increase of cocaine-related deaths that have opioids in them, predominantly fentanyl. So the cocaine death rate is being driven by the fentanyl that's in the cocaine. If you look at the right-hand panel, that's the same dark blue line, the overall death rate, but without opioids, you see there's the slope of the rate of increase is much lower. So the cocaine death problem is a fentanyl death problem. Among amphetamine type stimulants or methamphetamine, same picture, you see a big increase overall, but the amount to which the opioids are contributing is much less among methamphetamine related deaths. The right-hand panel is deaths without opioids. So you've got a slightly different pattern among the cocaine users, which has, by the way, been the main stimulant in Vermont. Fentanyl is what is the fatal ingredient in their overdose. For people who are overdosing from methamphetamine, it's a mixture of both fentanyl-related deaths and direct deaths related to the methamphetamine itself. There's been a huge effort. Vermont has been a leader in the development or the dissemination, the uptake of buprenorphine as a treatment for opioid use disorder. It's now in virtually every primary care clinic in Vermont. It's really a remarkable accomplishment that Vermont has achieved. However, we're starting to see some difficulty with these increased rates of stimulant use as to how it affects those patients. These are data from the state of Washington. 800 patients admitted to buprenorphine treatment. About 2/3 of them only met criteria for opioid use disorder. 1/3 of them met criteria for opioid use disorder and methamphetamine use disorder. So they came in using both drugs. these are the retention curves for those groups. The top line is retention on buprenorphine for the opioid only use group. And as you can see, retention goes out to about a 50% retention out to close to 800 days or a few years, which I think is pretty impressive. However, for the dotted line, those who also used methamphetamine, we see a much more rapid drop off in the first 100 days. And that, when you read the article and when you talk to some of the folks involved in producing that article, that drop off was not just people dropping out of treatment. It was, in some cases, prescribers discontinuing treatment for people using methamphetamine because there was this belief that if you're using stimulant, you're actively using stimulants, you should not be given buprenorphine. That I think is changing. And if there's anything that you hear me say today that you take home with you, it is kicking people out of buprenorphine treatment for using stimulants is a bad idea. It's probably malpractice. I know there are some cases in California of big lawsuits of doctors who have kicked people off from buprenorphine because they continued to use methamphetamine. With the drugs that are on the street right now, all having fentanyl in them and all being incredibly dangerous, to kick somebody off buprenorphine for almost any reason is really a dangerous decision. So hopefully that practice has been discontinued for the most part. I'm doing a lot of consulting in the South, Louisiana and Mississippi, and I get some of my physician colleagues involved to try to help change that practice, because there's still parts of the country where it is a standard clinical practice of, if you're going to keep using methamphetamine, then you're not going to get your buprenorphine, and very dangerous situation. Okay, impacts of methamphetamine. My colleague, Martin Paulus from UC San Diego, who actually visited UVM not that long ago, gave a grand rounds, published a great article earlier this year in JAMA Psychiatry reviewing the neurobiology and clinical presentation of individuals with methamphetamine use disorder. Just very briefly, a very brief overview. Martin's focus was really in two areas. I didn't think he did a very good job on the behavioral treatment section, but neurotoxicity and cognitive effects and cardiovascular and cerebrovascular symptoms. Clear, lots of data. The meth problem really exploded in the West Coast in the late 90s. That was about the same time that brain imaging technology started to be used in the area of addiction. So we have lots of brain imaging data on individuals who use methamphetamine. And Martin's article really does do a great job of summarizing that. But the overarching conclusion is that individuals who chronically use methamphetamine have an altered brain state that's consistent with degenerative central nervous system diseases, and that people who have been chronically using methamphetamine are not like people with traumatic brain injury. They actually are people with traumatic brain injury, that methamphetamine does damage to numerous areas of the brain that takes time to recover. For the most part, it recovers, but it's challenging for those individuals who've used methamphetamine. Soon after cessation of methamphetamine use, very big deficits in performance on motor and other processing tasks, verbal fluency and attention, and measures of memory. Even after 4 to 6 months, we see poor learning efficiency and comprehension, visual spatial processing, and other measures of cognitive function. So if your focus has been in treating individuals with opioid use disorder, as you start working with people with more methamphetamine use disorder, you're going to see more of this stuff. They don't think clearly. They have lots of psychosis. Their memory is impaired. Estimated more than 2/3 of those with methamphetamine use disorder show cognitive impairment. The extent of the impairment is associated with Greater impairment with older age, longer duration of use, injection route of administration, and greater frequency of use. So the heavier users have more impairment. And I think it's safe to say that there are some people who have used long enough and heavy enough that the damage to their brain does not recover. You see people who have persisting long-term cognitive deficits as a result of their methamphetamine use. And of course, if you're doing treatment, which involves talk therapy, their ability to follow through, to remember what they've been taught in treatment is significantly impaired by the deficits in their memory. In addition, Martin's article reviews the cerebrovascular and cardiovascular disease. Back when I was doing a lot of treatment with individuals with cocaine and methamphetamine use disorder in the 80s and 90s, our treatment centers had virtually very minimal medical involvement. They would walk past the physician's office maybe when they were coming in for their counseling sessions, but there generally was not a big perception of these folks as having substantial medical comorbidity with their substance use disorder. That's changed. With these stimulants, particularly with the current data on methamphetamine, we're seeing that there's the leading causes of death for people with methamphetamine use disorder are stroke and heart attack. And these are young people in their 30s and 40s having these disorders. And again, as far as the methamphetamine goes, it's probably related to the new formulation that we're seeing that produces a much more lethal form of methamphetamine. This is an article published in 2017 on stroke and methamphetamine use. 77 articles reviewed stroke in young adults, 81 hemorrhagic strokes, 17 ischemic strokes. And the hemorrhagic strokes, that is when the blood vessel in your brain bursts, is associated with injection route of administration. Ischemic strokes, where the blood vessel is constricted in your brain, more associated with inhalation, smoking or inhaling methamphetamine. So I'm going to talk about a number of other measures, and in all of them, injection users have much worse prognoses, much worse medical problems, much worse psychiatric complications. And so route of administration makes a difference in all of these things. And now that we're seeing these strokes and the cardiovascular issues, the treatment providers, you really need a medical component to your treatment. You can't just see these as people who need some kind of behavioral counseling by itself, because they have significant co-occurring medical comorbidity that needs to be addressed. And we are doing some training around helping even non-medical people recognize signs of stroke, because these are pretty common. I just did a session with the California Society of Addiction Medicine on this, and a lot of the docs were talking about how shocked they had been at the number of young adults they're seeing with stroke in their practices. This is an excellent article, a recent article on stimulant use in pregnancy by this group. I highly recommend this as really being a very comprehensive and current overview of our knowledge of what happens with stimulant use in pregnancy. In this article, they review a meta-analysis of 31 studies reporting that cocaine use during pregnancy is associated with increased risk of preterm delivery, low birth weight, small for gestational age, and earlier gestational age at delivery. Now, this is important because back when Steve was treating cocaine users in the 80s and 90s, there was a virtual hysteria about crack babies, and that the cocaine use during pregnancy was going to produce all these mutants that were going to be antisocial personnel. Well, there certainly are effects of cocaine use during pregnancy, but the hysteria was pretty much overdone about the impact on these children. Meta-analysis of methamphetamine use during pregnancy was associated with earlier gestational age at delivery, lower birth weight, smaller head circumference. There does seem to be pretty good evidence that infants with prenatal exposure to methamphetamine exhibit a more severe withdrawal syndrome, more jitteriness, drowsiness, and respiratory depression during their early days of post-delivery. And both of these drugs are excreted in the breast milk. And so if the mother continues to use breastfeeding is contraindicated. There was a study, there's been a couple of studies that we were involved with at UCLA. Chris DeRoth did this one of 204 methamphetamine exposed maternal child pairs, where we followed the kids collected data from them at 3 and 7 years post-delivery. All 204 were methamphetamine exposed, and we had a similar number of controls. At 3 years, heavy methamphetamine use by the mother was associated with elevated levels of anxiety and depression and attention problems in the kids. At 7.5 years, we saw poorer cognitive function. We did a study at UCLA where we looked at 4 to 5 year olds, and we had a comparison group. And we found that the biggest effect we could see was on their vocabulary. They seemed to be poorer at acquiring words. Their vocabulary was much more impoverished, and they were less fluent with their words. They spoke less, and their sentences were shorter, and they seemed to have more difficulty with using their language. This data on methamphetamine and violence, Australian group looked at this, and basically the data are that compared to non-users, people who use amphetamine have a 2-fold increase in the odds of having a reportable violent or hostile action that gets them into contact with either the medical setting or with the police. And that's related to heavy use, injection use, and psychosis. That is, these folks don't generally become violent unless they're psychotic under the influence of methamphetamine. And so that's developing protocols. If it's true that there is an increase in methamphetamine use in Vermont, and that there will be more of those folks showing up in the emergency department, developing protocols for de-escalating their behavior is really important, because you'll start to see a lot of them showing up in the ED with psychosis. Obviously, as with everything else, the COVID epidemic has affected our addiction treatment efforts. Nora Volkow published an article earlier, I think it was back in June. Her basic messages were that with our population that use tobacco, opioids, methamphetamine, any drugs that affect the lungs, you're going to see more complex COVID responses or more dangerous COVID responses. And also that because of many of the efforts we've taken to limit contact with each other, it's produced more social isolation, which produces more stress, more depression. And Nora's warning was we're probably going to see an increase in overdoses. Well, she was, not surprisingly, with Nora, she was right. There are data on overdoses. The gold line is fentanyl-related overdoses. This, assuming if you picked March 1st as the beginning of the COVID pandemic, you can see the escalation almost immediately with fentanyl, methamphetamine. The green one is cocaine and heroin. So you see this shot up, and somewhat of a reduction later, but still, if you look month to month, these are data on overdose deaths compared to 2020, the month compared to 2019. And in January, we were right about the same as we were in 2019. And then you see the escalation to by May, we were almost a 50% increase. Friedman has done some interesting work, just published this in JAMA Psychiatry. And looking at overdoses. Oops, sorry. And again, you can see overdose-related cardiac arrests, again, starting in March, and you start to see that go up, and the horizontal lines are 2019, 2018, and the average of 2019 and 2018. So clearly 2020 has shown an increase in overdose-related cardiac arrests. And he has an interesting twist in that he measures mobility of people by tracking cell phones and has shown an inverse relationship between overdose related incidents and people's mobility. As people stopped traveling around as much, as they stayed home more and their mobility went down, overdose deaths related. Now, obviously it's not a causal, but there is an interesting correlation between people being more isolated, being more staying at home, and this overdose death rate. Clearly, the assumption is, to some degree, that's a result of people being by themselves. If they're using drugs by themselves, they can't be resuscitated with naloxone as being part of that picture. Clinical challenges. If you've done your learning of dealing with addiction with opioids, as you start to work with individuals with stimulant use disorder, you're going to see a real different picture. Clearly, overdose death is an issue, but with these individuals with stimulant use disorder, they have a much different perspective on whether or not they're addicted. There's a much greater questioning about whether their drug use represents addiction or simply voluntary use. They'll often point to their opioid using colleagues and say, well, they're addicted because they can't stop. They have no ability to stop because they go into withdrawal. I can stop. I'm able to stop my use for periods of time, but then I go back, of course, because I want to go back. So if they don't view themselves as being addicted, they also have much greater ambivalence about their need to stop. And I'll give you some data on this. They have impulsivity and poor judgment, cognitive impairment, poor memory. A hallmark of stimulant use disorder is anhedonia. During the early months of treatment, it's not depression, it's this feeling of nothing gives them pleasure. Life sucks. Life just is. They say things like, if this is how it's going to feel to be sober for the rest of my life, I can't live like this. And so this anhedonia is an important, clinically important issue. Paranoia, as I mentioned, that can often continue even beyond their actual use. They can stop their methamphetamine use. However, the paranoia can persist for weeks or months. Not psychotic paranoia, but sort of low-grade suspiciousness. The police are outside their house, the people are listening to them, that kind of stuff. During their use, you see hypersexuality. When they stop their use, they often, many of the males will complain about not being able to function sexually. That becomes obviously an important clinical issue. Violence. And this Pavlovian triggering that occurs is really sort of the hub of their challenge. They don't know why all of a sudden something will happen and all they can think about is using. And that becomes sort of an overwhelming event for them. And it's caused by this Pavlovian trigger response that they have. Psychiatric comorbidity and retaining them in treatment is a challenge. Liz Evans from UCLA, now UMass, has just published some data that if individuals with stimulant use disorder are retained in treatment, their death rate is 1/6 of what it is if they're out of treatment. So getting them into treatment and keeping them in treatment reduces death rate. However, our challenge is, how do you do that? This gives you some data sort of reflecting on this issue of this just published in Addiction. They looked at different types of individuals with different types of substance use disorders who are in behavioral treatment and looked at their dropout rates in the first 90 days of treatment. Heroin users, tobacco users, alcohol users in this study looked at, said about 25% discontinue their treatment in the first 90 days. Cocaine users, it was about double that, and methamphetamine users, even more than that. So these individuals with stimulant use disorder are not easy to keep in treatment. I mentioned there's some groups that are particularly challenging. Individuals who inject, individuals who use daily. They are come into treatment with much greater difficulty stopping their use and successfully engaging in treatment. Women come in generally with more reports of physical and sexual abuse and higher rates of depression and anxiety, which definitely needs to be addressed as part of their treatment. The homeless, chronically mentally ill population has a variety of challenges where their homelessness, their chronic mental illness also has to be addressed as part of their treatment. Men who have sex with men have been a particularly important group. They have higher than normal rates of methamphetamine use. The methamphetamine use gets very tangled up with their sexual behavior. That puts them at very high risk for HIV transmission. And so there's been a lot of work done with that population. Finally, as we've mentioned, individuals on medication treatment for opioid use disorder. We're seeing increasing numbers. In California right now, the data are that 50%, just about 50% of the patients on buprenorphine are also using methamphetamine. I've checked around in Vermont. I haven't done any systematic study, but the couple of the docs I've talked to, including John Brooklyn, said they thought it was in the 15 to 25% range of their buprenorphine patients who also used in Vermont cocaine, although I suspect they'll see more with methamphetamine. But so it's a big problem with that population. A couple of quick things that I think I'll skip over this in the sake of time. There are some new overdose strategies of how to get people's temperature down. The cause of death from overdose from methamphetamine often is hyperthermia. That is, your body temperature gets up to 108 or 109, and the challenge is getting the body temperature down very quickly. This article by Wang talks about a new procedure of putting people in body bags and covering them with ice to bring it down, and seems to have pretty good effect. In EDs, you tend to see individuals with methamphetamine use disorder showing up with behavioral disturbance. That is short for psychosis and methamphetamine intoxication. You also see tachycardia, extreme hypertension, and again, 1 in 20 comes in with this hyperthermia that is can be very dangerous. As I mentioned, many of the individuals with meth use disorder are not interested in treatment. They're ambivalent about their need to stop. So we have to find ways of giving them some kind of harm reduction strategies. Certainly giving cocaine users naloxone, probably methamphetamine users as well, since there's fentanyl in their drug, that may be a very important thing to provide. The other things are similar to opioid use harm reduction strategies. There are some places now that are giving people glass pipes to encourage them, if they're going to use methamphetamine, to smoke it as opposed to injecting it. And there are other things to just help them with their general hygiene, because they often go long periods of time without bathing or brushing their teeth or other things that can be done. And again, as I mentioned, this is data from Washington. Syringe exchange program have 443 opioid users, 140 methamphetamine users. When surveyed and asked about their interest in stopping or reducing their drug use, 82% of the opioid users said, yes, I think I probably should reduce my use or stop or get into treatment. Only about half of that number who were using methamphetamine reported the same interest in reducing or stopping their use. So again, one of our big challenges is our treatments have to find a way to address this resistance, this lack of understanding of the need for treatment and drawing them into treatment. And in the absence of medications, that's a challenge. Okay, I'm gonna, since I mentioned in the core presentation, I spent way more time on treatment. I'm gonna give you a real rapid fire and quick summary of what we know about treatment. This is an article published in 2018, done by a group in Oxford University. Comparative efficacy and acceptability of psychosocial interventions for people with cocaine and amphetamine addiction. This is a very prestigious group. They reviewed 50 studies with almost 7,000 participants, looked at 12 different psychosocial approaches for cocaine or amphetamine addiction. Their conclusion was the combination of contingency management and community reinforcement approach was the most efficacious and most acceptable treatment, both in the short and the long term. And if you read this meta-analysis, much of the evidence for this statement comes from the University of Vermont, from Steve Higgins and Stacy Sigmund and the team at UVM. Purdue were the first to do these studies to show the efficacy of these approaches and really provided the really foundational data for this conclusion. We go on to some other ones. This is a Corcoran collaboration review from 27 randomized trials. The comparison between different types of behavioral interventions showed results in favor of treatments with some form of contingency management in respect to both reducing dropouts and lowering cocaine use. Mike Farrell and his team in Australia published in a journal in The Lancet in 2019. Psychosocial interventions other than contingency management have weak and non-specific effects, and there are no effective pharmacotherapies. So the Australians concluded that only contingency management is effective. This was published in June in Drug and Alcohol Dependence here in the US. 44 studies reviewed. While contingency management intervention showed the strongest evidence favoring outcome, tailored cognitive behavioral therapy with or without contingency management were also effective. And there's two other meta-analyses, both saying the same thing. Contingency management unanimously has been found to have the best evidence of effectiveness. CBT has some evidence, community reinforcement approach has some evidence. Motivational interviewing, although not for stimulant use disorder treatment particularly, but in general, in working with individuals with substance use disorder, particularly those with ambivalence, is likely to be a good idea. And I would argue with some of the data I have that physical exercise has some benefits. For those of you not familiar with this term, contingency management is a technique employing the systematic delivery of positive reinforcement for desired behaviors critical to the reduction of stimulants, use of stimulants. In the treatment of methamphetamine or cocaine dependence, vouchers or prizes or gift cards or incentives of some form can be earned for submission of drug-free urine samples or attendance at treatment sessions or some combination or other paradigm. And it's not quite this simple, but it's really the use of positive reinforcement to reduce drug use, and it works. Brown and DeFolio just published this article in JSAT, a review of 27 studies, contingency management intervention for people with meth use disorder. They found in 26 of those 27 studies, methamphetamine use was reduced, longer retention in treatment, more therapy sessions attended, higher use of other services, reduction of risky sexual behavior, increase in positive affect and decrease in negative affect. So there's really an overwhelming set of information on the benefits of contingency management. So you're thinking, then that's what we're doing, right? That's our treatment in the United States. Well, not exactly. There's a variety of things. Historically, there's been some staff, the third bullet, some staff resistance to the idea of using incentives. That's pretty much going away. There are some issues around where do we get the money for the incentives? Like where's the bank we go to pay for these incentives? That's actually been, that issue has been reduced with some of the federal funding that's been out over the last 3 years. The big issue right now is we have Medicaid regulations that interfere with giving people more than $75 in incentives. We're working on that, however. We've got some efforts to get that changed, but right now that's one of the biggest obstacles to the use of contingency management. And it clearly is a big deal because it's the technique that works, and we have to find a way of getting it into application in routine substance use disorder treatment and in other settings like primary care settings where prescribers are trying to get their buprenorphine patients to reduce their meth use. There's some really interesting new technologies where you can use an app-based system to deliver contingency management. And I think there's some great new strategies. We just have to figure out how to get some of these restrictions reduced. I mentioned I've done some work with exercise with individuals with methamphetamine use disorder. Exercise did a lot of good stuff to help increase their heart rate variability, reduce their anxiety and depression, their craving. And when patients were in a residential setting who got the exercise, they then were discharged into the community. We saw lower relapse rates among those who had the exercise intervention. Medications, lots of interest in this, of course. The leading candidates right now are topiramate, modafinil, and bupropion. None of them have FDA approval, and there's still lots of questions about, do they actually work for reducing cocaine use among patients? With methamphetamine use, the leading candidates are bupropion and mirtazapine. Just a second randomized clinical trial published in JAMA on mirtazapine. So it has 2 randomized clinical trials. That's probably the leading candidate. I have to say though, when you talk to the docs who are using any of these medicines with individuals with stimulant use disorder, they don't describe a very robust effect. They say, well, a little less depression, a little less craving, but it's not like giving an individual with opioid use disorder a dose of buprenorphine or methadone. So we're a ways away with medication treatments. However, we do have a behavioral treatment that works really well if we can figure out how to get the regulations changed. Summary, the meth use and the cocaine use we're seeing now is involved with a lot of overdose deaths. We have behavioral treatments, particularly contingency management, that works. And we have no medications currently for the treatment of individuals with cocaine or meth use disorder. And I think that's it. Questions? These are some connections to the Vermont Center on Behavioral and Health and the Center for Rural Addiction. So Nicole, back to you, or back to Steve.
Well, you have some questions lined up, Rick. I don't know if you can see your Q&A. If not, I can read them.
Well, let me click on that. I wonder why overdose deaths are the primary drug use data. It seems like drug use prevalence would be better from my limited understanding. Okay, I think that during the opioid crisis, drug use prevalence data were always one of our major measures. They still are. We still use the National Household Survey. But I have to say, in my 40 years of looking at the National Household Survey data, drugs like methamphetamine and heroin have been massively underestimated by those self-reports of people. I was a member in the National Household Survey this year. I had a surveyor come to my house. I was randomly selected. And the lady came and knocked at the door we talked with each other with our masks on. And I would have been reluctant to say, yes, I'm doing this illegal behavior that is very stigmatized. I just think that once the opioid overdose death data started to be the driver of policy, I think that we sort of moved away from, well, let's ask people what they're using, to let's look at what's killing people as the main metric we want to use, and use that is where we should be focusing our effort. And so I think that overdose death data have really become sort of the central metric that we're using. And you can argue it either way, but I think that's what's happened. Are you seeing any differences in stimulant use in patients on sublingual buprenorphine versus sublocade? I don't know the answer to that. I know In the Clinical Trials Network at NIDA, they're looking at that issue, but I don't know where they are with the data on that question yet. And since I'm not a prescriber, I can't talk about my own experience. With legalization, decriminalization of all drugs, as well as a system to legally purchase pure substances, reduce the overdose rate. I don't know the answer to that. I know when you when you decriminalize a drug and you legalize a drug, the use rates go up. As we've seen with cannabis in Colorado and other places where decriminalization, legalization has occurred. With these drugs, I don't know. I think it would be, I don't know how much you can generalize from this. We could look at what's happened in Portugal where drugs have been decriminalized. I believe you've seen a reduction in use. I don't know about overdose death rates. Or would more people use these dangerous substances? Well, you would see more use for sure. The question is, if you could go and buy into your drugstore and buy a dose of methamphetamine or cocaine, you could be pretty sure that what you're getting doesn't have fentanyl in it. I mean, part of the issue with the illicit market is that the illicit market, they mix things together and you don't know what you're buying. So that does increase the danger of the drug. I'm not sure decriminalization, legalization with these drugs, I don't know. I can't give you, I don't have an opinion on that. And make a list of references available to view. Yes, I can send you, I'll send it to Nicole and she can make sure to get you a list of I just have a whole big bunch of references. And also this PowerPoint will be available that we'll make available to people. Also interested to hear if you say words about infection risks, bacterial HIV, methamphetamine use relative to injection use of other substances. There was, and I don't know that this has been systematically looked at, but there was some data back in the earlier meth era that individuals who use methamphetamine were more at risk for HIV and other diseases because their practices, their needle practices were particularly unsanitary, and it put them at greater risk. I don't know that there's any systematic data on that, but it was, it's probably something we should be looking at. The individuals who use meth, they go on these long runs of use where they will go 3, 4, 5, 6 days with minimal sleep. They're psychotic, they're injecting repeatedly. They develop a tremor, so their needle marks tend to be really a mess because they can't hit the vein anymore with their syringe. So it becomes medical, a real challenging group medically as well to treat.
So Rick, we're about out of time at this point. You've done a wonderful presentation and I really appreciate it. And I apologize to any to those in the audience who submitted questions we couldn't get to, but unfortunately we're out of time. So thanks again, Rick, for just an outstanding presentation, and thanks to everyone in the audience for participating. Have a great holidays and New Year, and we will see you back on our first presentation in January. Thanks, everybody.
Thank you.